Hello, PT on Ice Daily Show. How are you? Good morning. I'm Dr. Lindsay Huey, lead faculty for extremity management. So pumped to be with you all today on a clinical Tuesday, my favorite day of the week. Today, we are going to talk about stopping the scope for degenerative meniscus injury. But before we dive in, I just want to remind you to check out the extremity management team on ptonice.com. Check out our new awesome website. We have a host of courses coming up to you throughout the year. So please join us. One coming up really recently that I'll be doing will be the first weekend of August in Arizona with Megan Daly. It's going to be such a blast. So please join us for that. And then we have lots of spots actually left in some end of the year courses. So check out if you aren't ready in the summer to take a course, you're on vacation with the family. We have courses in October and November that are open. I'll actually be in Windsor, Colorado in November. So I would love that class has quite a few spots right now. So I would love if people would dive in with me at the end of the year, November 5th. 6th. So, team, ptonice.com, check it out. But I'm really eager to get at the topic at hand rather than talk about all of our courses. So, recently, 2022, literally this summer, JAMA put out this amazing RCT concerning meniscal repair compared to surgery. So, what I want to do is unpack the study just a little bit for you because it was a very rigorous study with a 5-year follow-up that's pretty significant. And before I kind of tell you the conclusion and why stop the scope is what I implore us all to do as a society and do PT first, I want to tell you about the study a little bit. So the title of this study was the effect of physical therapy versus arthroscopic partial meniscectomy in people with degenerative meniscal tears. So this is open and out of JAMA network, 5-year follow-up of the ESCAPE randomized controlled clinical trial. This was by Noordoen and et al. And team. So what this team did is they had 9 participating ortho clinics out of the Netherlands. They took patients ages 45 to 70 with symptomatic degenerative meniscal injury. And this was confirmed on MRI. These humans all had a BMI 35 or less, and no ligamentous injury was on board or no acute injury or lock knee presentation. So consider the patient population that we are presenting on and studying. Everyone had less than a grade 4 on that Kellgren and Lawrence scale. So that grade 4 is severe signs of NEO-OA. Joint space narrowing is severe, and then buildup of or lots of buildup of osteophytes. So consider it was grades 1 through 3. And they block randomized into a surgery group or a PT group. After randomization, people either got surgery. So within 4 weeks of randomization, they either got arthroscopic partial meniscectomy care, or the other group got PT within 2 weeks after randomization. Care for the people that got arthroscopic partial meniscectomy included a post-op instruction handout, just letting you know how do you heal and do things after post-operative care type things, and then just a home exercise program. So general exercise, and I don't have details on what that included. There was an 8-week checkup for the people status post meniscectomy. And then after that 8 weeks, if possible, there was a delayed recovery, they would receive PT care. Those with PT care, they had 8 weeks of 16 sessions, and their sessions were 30 minutes each. And they kept that pretty standardized, and I'll let you know what those exercises are in a bit. And that was all PT led, so not tech-based, but a physical therapy, skilled therapy. And then what they did is they had patients fill out questionnaires about functional outcomes. So they had self-administered questionnaires at 3 months, 6 months, 1 year, 2 years, and 5 years. So this is pretty significant time span and periods that they gathered data. They also took weight-bearing radiographic images at baseline and then that 5 year just to see were there any signs of progression of OA in either group. Of the 321 patients, they actually retained a really good amount, which is impressive. 278 were retained at the 5 years. This comparison, so PT versus partial manisectomy, what they found was that the overall crude difference between physical therapy and arthroscopic partial manisectomy, when they look at those functional outcomes, was not significantly different, meaning in pain and overall function, not a big difference at the 5 year, whether you got surgery or whether you got PT. So here is this, in my opinion, kind of underwhelming conclusion, but exciting when we give it a spin. So here's the underwhelming part from JAMA. This RCT found that exercise-based physical therapy was not inferior to arthroscopic partial manisectomy over a period of 5 years for self-reported knee function. We observed a small and comparable progression of knee OA in both groups. Findings from this trial further support the recommendation that exercise-based physical therapy should be the preferred treatment over surgery for degenerative meniscus tears. So I freaking love that last part, right? The preferred treatment over surgery, hence stop the scope. But that first part, right? The RCT found that exercise-based physical therapy was not inferior to arthroscopic partial meniscectomy. I get it. This is a medical journal, right? So they are probably trying to show that possibly that surgery is superior. But I'd love to see us switch that narrative a little bit. And I think it comes down to how we infuse fitness and our exercise choices. So what I'd love to do is unpack what they actually did for exercise and really suggest a way where we can have switch the narrative a little bit, where we're proactively saying physical therapy is superior to arthroscopic manisectomy. So here's the team, what they did, this 30-minute session, what was involved. So I literally printed out the protocol. It's right in front of me. So they first, in the 0 to 8 minutes, they did a stationary bike for a warm-up, some kind of cardiovascular training. And that they would gradually increase that. They started at 7 and they'd gradually increase them. Then they would do some pulley work with the ankles and the hip, 3 sets of 12. They do calf raises on a leg press. 3 sets of 12. They did standing hip extension in multiple planes, 3 sets of 12. Balance on a wobble board with both feet, 3 sets of 12. They do some stair walking, running, jumping, just gradual progression according to the individual. That was about 10 minutes. They would also start challenging by throwing a ball for some dynamic stability. They did some calf raises standing on one leg, 3 sets of 12. They did some leg press. And they did 3 sets of 12 of that. Some lunges, but the funny thing about these lunges is it's less than 90 degrees, 3 sets of 12 of those. We can do better here. And then balance on a wobble board 1 foot for about 3 minutes. And then they would end out with some kind of crossover training, cardiovascular, like cool down from the session. So that was the session in a nutshell. Plus, they would do an HEP 2 times a week. And that involved 60-second single leg stands and then 3 sets of 10 of step downs. So when we look at this program as a whole, I'd say it's decent, right? It does, multi-segmental joint motions. There's some lunges in there. There's some squats. I cringe a little bit that the lunges are less than 90 versus going to that 90, because I think we get a little bit better activation in that quad, hamstrings, and glutes when we go further. But overall, decent. But what I would love to see to get to that place where we are saying exercise is superior to partial meniscectomy is infusing fitness. And when I say infusing fitness, what do I mean? Well, I'm going to tell you what I mean. Manual therapy. So no manual therapy was on board, right? When we think about ICE and our pillars, right? Fitness forward, manual therapy skilled, psychologically informed. Where were the pillars? Right? So where was that symptom modulation where we work on restoration of motion and helping with range of motion, right? Knee flexion and extension, mobilization needs to be on board in these humans. And so that was missing. And I get in a study, in a randomized control trial, we're trying to really standardize care. So I totally get that, right? But in the day to day, how do we make this superior? It's manual therapy involved in the care, especially in the beginning. In addition, doing some kind of for manual therapy, like maybe dry needling or myofascial decompression to those hamstrings and popliteus, common areas involved in being irritated when we think of meniscal degeneration. There was no local quad strengthening on board done. Yes, a lot of the exercises involve the quad, right? Obviously, lunges do, squats do, but did we actually isolate the quad ever? So I would advocate that doing some quad, whether it's long axis or a long, excuse me, LAQ, where you do a little extra lift and hold. And for those who are just at extremity management and athletico with myself or with Mark in Maryland, you know that extra little lift, that kick that it gives, where we really dial in that quad set. In addition, doing some really localized posterior chain strength, like a hip thrust, to build up the glutes and the hamstrings. We need some of that focused work to help make that knee more resilient and strong. Reactive neuromuscular rehab is something we really advocate in extremity management. And what's neat is I did see that in this program. So I really liked that they incorporated some wobble board and ball toss training. One thing that we really advocate that's a little bit different when we think about fitness forward. Reactive neuromuscular training is not only what do we want to train the patient to not fall into the dysfunction, we actually want to train into the dysfunction, meaning that femoral adduction internal rotation that we often are telling patients to stay out of to protect their knee. We actually end stage want them moving into that, right? So that they're not afraid to pivot and twist their knee. They're not afraid that if they twist it, they're going to hurt their meniscus again. We want to build up that resilience and confidence so that fitness forward best practice degenerative meniscus care involves reactive neuromuscular rehab that actually allows that dysfunction to happen. And then I did see that, they were doing some walking and running training, which I do think is great. But we like to think of functional tasks like walking, stair climbing, and step ups as being a very graded exposure and individualized thing because these are the activities that are really bothering these humans. They're coming in with complaints of the knee pain with those specific activities. So I can't help but think in a randomized controlled trial fashion. That might have lacked some individualization, right? If you're having the patient do the same thing every time and not really dialing in that individual's needs or talking to them about their fears of that movement, we're missing the boat. We're missing that psychologically informed piece, right, of the fitness forward care. So overall, pretty psyched about this JAMA 2022 RCT. It was well done and it had great conclusions. But what I want to see is that the next JAMA conclusion to be a little stronger. I want exercise based therapy is superior to arthroscopic partial manisectomy over a 5-year period. And I think that starts with infusing fitness forward care that looks after the individual, that includes some manual therapy for symptom modulation and includes some local strengthening to those quads, hamstrings, and glutes, plus that reactive neuromuscular training into the dysfunction. And top it all off, some graded exercise to the activities that are important to the human. In summary, hashtag stop the scope, hashtag infuse fitness into your human's world. Thank you for being with me on Clinical Tuesday. Have a beautiful rest of your day, team.